that achieve cost savings by focusing on reducing inpatient costs. This webinar summarizes the total cost of care for Medicare Fee-for-Service beneficiaries with 25 chronic conditions, comparing the cost between Maryland and other states. We do ask that you hold questions until the end of the presentation. Feel free to put them in the chat, or after the presentation, we will allow attendees to unmute themselves. With that, I'll turn it over to Acumen. We have Sam Bounds and Joyce Lamb here today. Sam will take the lead on today's presentation, and Joyce will be on to help answer questions. They will be presenting on the evaluation of Maryland Medicare spending on chronic conditions. So thank you again, and Sam, whenever you're ready.
Thank you, Lexi, and I appreciate that introduction. I'm Sam. I'm here with Acumen, the contractor that conducted the analytics for Maryland spending on chronic condition. And with Lexi's great introduction, I think we can skip through ahead to our content for today's meetings. So in terms of background, Lexi's provided us a lot of good information, some general benchmarks that a lot of people on today's call are likely familiar with, is that chronic conditions are a substantial driver of health expenditures in the US. Just a benchmark number here in 2016, 1.1 trillion was spent in the direct treatment of chronic conditions. Maryland's all-payer model resulted in a reduction in this spending when first implemented. In the first 4.5 years or so, they showed growth in spending that was 2.7% less than the comparison group of the other states. And so trying to build on this success, today we're going to evaluate the recent spending of chronic conditions, so that policymakers and care providers alike can be informed, and where the cost saving opportunities are, and how Maryland looks in terms of managing this particular patient cohort. And so more directly, this is kind of our research statement for today. Evaluate Maryland's Medicare Fee-for-Service spending for chronic conditions against national results to identify areas of potential improvements in existing state programs. So moving on to the next section, the evaluation and approach, we'll want to share with you our methods rather quickly, and then we can get into findings and summaries. But these are the data sources that we used. We used Part A and B claims from the Chronic Condition Warehouse was our source of the Medicare claims, along with beneficiary enrollment data. When we talk about cost in the slides today, we're talking about allowed amounts. Allowed amounts are the allowable paid or reimbursed amount that Medicare could reimburse a service for. So that doesn't take into account the patient's liabilities or other co-insurers' contributions to paying for these services. This is a nice way to evaluate spending when comparing against vastly different providers across different states, as they'll all have a different sampling of beneficiaries and rates of the beneficiaries' contributions to costs. And we don't want those differences in costs to be observed in our analysis, as it's kind of outside of the provider's control. We looked at all Part A and B claim settings, and later in the slides today, we break out our costs by this. So acute inpatient will, of course, be a focus as one of the largest areas of spending, or at least one of the less expensive settings. But we've also evaluated other institutional settings, such as the outpatient, post-acute care settings, and home health, along with more fee-for-service like care, like Part B physician and supplier claims or durable medical equipment. In terms of our claim sample, we have a full sample for Maryland, and we're comparing it to the nation on a 5% sample. And so this is an area of improvement that, we'll identify at the end as well. It's nice to always have a larger sample, but for the nation, 5% appears to be sufficient in terms of gathering overall trends. Our study period, I would define as 2019. So as we go through these slides and look at utilization and cost figures, those are calculated for the annual aggregated rates in 2019. Our patient cohort or beneficiaries that we are stating to have a particular chronic condition is identified in the year prior, so in 2018. And now this last bullet will address at the end of this presentation, which states, we wanted to look at Maryland's care for chronic conditions without the conflating factor of the COVID pandemic. And so we focused on 2019. We know that post 2020 and onward, there's been radical changes to the healthcare system and even beneficiary behavior in care utilization. I think some general research out there shows a great reduction in inpatient utilization and emergency department visit utilization during the peak of the pandemic in March and April of 2020 during the stay-at-home order. And a gentle, gradual recovery to a utilization rate that is comparable to that prior to the pandemic. Though some research has observed that the inpatient setting actually never fully recovered in terms of that utilization rate. As a comparison to pre-pandemic to 2019, it's been seen to be at 80 to 90% the utilization of or the number of inpatient admissions and cost utilization post-pandemic prior compared to pre-pandemic. And so with this in mind, we wanted to essentially rinse and repeat our analysis, looking at as much as current data as we could look at and data that is as past the peak of COVID as far as we could obtain. We conducted this work in quarters 4 of 2022, and so to allow for enough time for claims to mature and settle in final action, we studied the first 2 quarters of 2022 to see how these trends that we'll be talking about today persist in more recent years. So to define patients with chronic conditions, we use the chronic condition categories as defined by the Chronic Condition Warehouse. They had 30 different categories that they've defined using ICD-10 diagnosis codes and a particular algorithm to favor claims in which they observe these and how often they observe them. So this algorithm, as noted, was ran in 2018 to updated to identify the beneficiaries so that we can analyze their costs in 2019, with the assumption being for a chronic condition that they still have this condition in the subsequent year. Titles become what they are over time. They're adapted and used for other things. And so we felt that while they're called chronic condition categories, there was 5 in these definitions that didn't meet our research needs of being a chronic condition. And so I've been excluded from this analysis. AMI, cataract, hip pelvic fracture, pneumonia, and stroke. We identified these as being more acute in condition, and in some places we like to look at the numbers in aggregate. We're looking at number of chronic comorbidities per patient, or looking at spending or certain care utilization in aggregate across the chronic diseases. So upfront, we've removed these. The last part of the chronic condition warehouse algorithm that we emulated in the 2018 data was identifying the diagnoses codes mapped to a particular condition on particular claims in 2018. And then once we've identified those patients, they were candidates for our study in the 2019 cost analysis. Here we have an example of asthma. Many of the definitions follow this pattern, not all, but often it's one institutional claim, such as inpatient or skilled nursing facility, or two outpatient or Part B physician and supplier claims with diagnosis evidence of the chronic disease. Great. So we'll move into findings now. This is going to be the outline of how we run through how we assessed the spending and the chronic condition prevalence in Maryland. We'll start broad and narrow in. So quickly, let's orient ourselves to the volume, look at some annual spending figures, and then towards the end, start to zoom in a little bit or pick apart particular conditions or particular claim settings or care settings where the cost differs for Maryland between other states. So starting with prevalence. Here we have a table showing the number of beneficiaries per 100,000 beneficiaries with a particular chronic condition. As identified in our analysis, we have a summary row at the top for any condition across the 25 that we've defined, one or more. And then the subsequent rows are actually sorted by Maryland's frequency. That doesn't necessarily equal the other state's frequency. And then in the third column, the MD divided by other, that's showing a ratio of Maryland's number of beneficiaries per 100,000 with a particular chronic condition relative to other states. And so overall, one or many chronic conditions of the 25 we've assessed, there was about a 1.12 ratio. That translates to about a 12% difference of Maryland having more patients with chronic condition compared to the other states. The lowest prevalences were COPD, heart failure and non-ischemic heart disease, and Alzheimer's disease. And where this ratio is the highest is glaucoma, breast cancer, and endometrial cancer. We'll also want to know a little bit about the comorbidity or having more than one chronic condition per beneficiary. And we see these to be largely similar between Maryland and other states. I've included the distribution to kind of illustrate that point. At the average, sure, Maryland is slightly higher at 3.78 compared to other states at 3.73. They're equal at the 95th percentile. So for that mean to be higher, there's a little bit more of a right tail skew for Maryland. So moving on to annual spending. In aggregate, across all 25 conditions, if we just lumped all these beneficiaries together, Maryland's mean annual spending per beneficiary is higher than other states by about 9%. There is a right skewedness to both of these distributions, both for Maryland and other states, and Maryland's skewness is greater. And in later slides, I'll show another statistic that points to that. So looking at the median, the differences are smaller. Maryland is 6.6% higher at the median. That difference in being higher at the median, being higher at the mean than the median is showing Maryland's higher skewedness or having more outlier expensive beneficiaries in terms of mean annual cost. When you go by condition, it can vary. While diabetes and rheumatoid arthritis and osteoarthritis are the most common conditions, so we definitely wanted to zoom in on those. The mean annual cost per beneficiary the differences aren't as large. Whereas for the cancer conditions and cardiovascular conditions, there shows to be the largest difference, in which Maryland is more expensive than other states. Where Maryland is lower in mean allowed amounts is concentrated in the neurodegenerate conditions. And we'll see this in the next slide. But the neurodegenerative conditions include Alzheimer's, dementia, and Parkinson's. So I'll give a moment for those to take this data in. All this is showing is the average annual per beneficiary spending in Maryland in blue, and compared to other states in red, stratified by condition. That's what's listed out on the bottom. It's a lot to look at. At a glance, what you'll see visually is blue is taller than red, right? And so that's what was summarized on the previous slide. Generally, Maryland's annual per beneficiary spending on these chronic conditions is more expensive. Again, the largest difference we see is for cancer, that for endometrial cancer, urologic cancer, lung cancer has a substantial difference, and heart failure and non-ischemic heart disease. And then where you can see this trend reversed is in the second condition listed, Alzheimer's disease, as well as dementia and Parkinson's. And then our third section, we'll be looking into highlighting some of those diseases I just mentioned, right? Where Maryland is less costly and more costly, or the condition itself, I believe we're going to look at diabetes, is just highly prevalent in both populations, and look at the different cost settings or claim settings in which cost is, and how those compare in a more granular manner. So this was my promise to speak to the right skewedness of this distribution a little bit more. This first table is showing the percentage of total spending on a particular chronic condition that is spent on either the top 10 or top 5th percentile of costliest beneficiaries. And so there's a range here, is because we've calculated it independently for each condition and then showed the lower and upper bound. But essentially, this is saying, let's focus on the top 5th percentile of your costliest spendings. How does your total resource use respective to your state compare to other states? And so on average, there's about a 3 percentage point difference between Maryland and other states of spending a higher proportion of their total cost for a condition on these costly spendings, which again just speaks to right skewedness, or the high resource intensive beneficiaries really pushing around these distributions and being a significant contributor to cost. In the graph, you can visually see these comparisons. I've noted down where the highest and lowest differences are in terms of percentage points. The highest differences for the top 5th of the highest differences in spending, proportion of your total spending spent on the top 5th costliest patients, is dementia, Parkinson's, and osteoporosis. That's the largest difference, where Maryland's spending more on this particular set of patients. And the lowest difference, while Maryland is still higher, but the differences are closer to a 1 to 2 percentage points, are the cancers again. So cancer urologic, cancer lung, and cancer colorectal. So in this final section, we're going to zoom in on at least different claim settings and how they look on similar metrics, on average spending, on proportion of patients using this utilization compared from other states to Maryland. And then we'll even just look at that service utilization in isolation, abstracted away from cost, just to see the differences. So we're going to examine a couple specific conditions in the following slides. Diabetes, because of its high prevalence, neurodegenerative conditions. This is where we saw Maryland had a lower mean annual spending per beneficiary. And then the cancers, which we saw Maryland having the highest difference and the highest mean annual spending per beneficiary in comparison to other states. So looking at both sides, starting with diabetes. I want to take some time to explain the table and get us all familiar with it, because as we go through the other conditions, we'll look at this table again. The only change will be, instead of looking at diabetes, we'll be looking at Alzheimer's disease, dementia, Parkinson's, etc. So in our first column, we have a different claim setting. Acute inpatient, outpatient, Part B, physician supplier claims, institutional PAC, home health, and DME. I'd pause to define institutional post-acute care as a skilled nursing facility, long-term care hospitals, and inpatient rehabilitation facilities. And it doesn't include home health. Home health is stratified out on its own, given its kind of differences in spending and intensity of care. Next, we actually have two metrics that we're going through for within each of these claim settings. We're going to look at the percentage of the beneficiaries in that condition that are receiving these services, have non-zero cost in a year. So another way to interpret this first row would be Maryland, of the diabetes patients that we identified in 2018 for Maryland. In 2019, 18.9% of them went to the acute inpatient hospital at least once, if not more. Whereas other states had a higher inpatient admission rate, at least as a share of their beneficiaries, at 20.2%. The next metric that, and final metric that we're toggling or kind of jamming into these claim setting lines is the mean allowed amount, annual allowed amount per beneficiary for that claim setting. And so it's similar to the statistic I've been rattling off earlier, but now specific to the setting that we're looking at. So acute inpatient cost would be specific for the second row. And so what you see for diabetes is a lower utilization or a lower prevalence of or percentage of beneficiaries in Maryland going into the acute inpatient setting compared to other states, though Maryland is more expensive. And we know that based on Maryland's inpatient reimbursement model differing from the nation. And we'll see that while inpatient costs at Maryland are more expensive, the utilization rate is actually less in many of these cases, and we'll come back to that point. So continuing on to look at diabetes, for outpatient, institutional PAC, home health, and DME. And we'll throw acute inpatient there as well. Maryland has a lower utilization. And for Part B, physician and supplier, they have a slightly higher utilization, though that as a setting is kind of an interesting aggregation. I think the cost is interesting, the prevalence, there's a lot that goes into Part B physician and supplier claims. In terms of average cost in acute inpatient, outpatient, and Part B physician and supplier claims, on average, the mean annual amount spent per beneficiary for these claim settings is higher in Maryland compared to other states. Even and then so there might be fewer beneficiaries going into the outpatient for example, at 63.4% for Maryland compared to the 77.3% in other states. But when they go into the outpatient, they are incurring more costs. So next we have the same table, but we're looking at the 3 conditions where the total mean annual spending per beneficiary is less in Maryland as compared to other states. So there's Alzheimer's disease, Alzheimer's, dementia, and Parkinson's disease. And again, what you see is a lower utilization of acute inpatient care. Scanning quickly through these, you should also notice that apart from Part B, physician and supplier claims, which are slightly higher for Maryland, but almost on par, the remainder of the settings and for almost all conditions is lower utilized for the patient populations. There's a lower percentage of patients with these conditions receiving a service in any of these particular settings. Kind of going along with the finding that we got for total spending, you'll see for almost all these settings, but not quite, and definitely excluding acute inpatient, which we know is going to be more spendy. The inpatient, the institutional PAC, the home health, the DME, and outpatient, at least for Alzheimer's disease, on average is less for these patients. Now, outpatients helpful to look at as well. We know overall for dementia and Parkinson's that the mean annual spending is less for these patients, but on average, their outpatient and inpatient costs are actually more. And so that's really being driven by the lower utilization to drive that ultimate total figure to be less. So this is the contrast. This is the conditions where we're seeing Maryland particularly more spendy than the other states, focusing this time on endometrial cancer, urologic cancer, and lung cancer. For the first time in the tables that we've looked at, we have inpatient utilization rates that are actually higher in Maryland compared to other states. And this is rare. We'll look into just inpatient utilization across all the settings in a moment. And the statement I made isn't exactly true for urologic cancer. That's 23.9% compared to 24%. They're about even. But for lung cancer and endometrial cancer, there's a higher inpatient utilization rate. Well, we know inpatient on average is reimbursed at a greater rate in Maryland. And so this is going to be a big driving force in cost, and the total annual spending, like for it to overcome this difference in inpatient admission and higher inpatient reimbursement is going to be, it's going to take some substantially lower care giving in the other settings, which we don't particularly see. They're little higher utilization, at least for endometrial cancer and outpatient, less for urologic cancer and lung cancer. Though again, on average, the patient for all 3 of these conditions, when they go into the outpatient, the reimbursement rates are substantially more, on the order of $2,000 to $3,000. So this brings us kind of to our final drill down, and as we go from really broad to really narrow, we look at the cost overall, we look at the cost by the settings, we see this trend within acute inpatient hospitals, even PAC utilization, and now we'll kind of focus in on the utilization rates rather than just the cost itself. And I think this is a helpful exercise, especially when we just state the given of Maryland inpatient being reimbursed at a higher rate. So actually, Maryland actually has a lower rate of acute hospitalizations across most of the conditions. So the ones we highlighted, we saw it lower in diabetes, we saw it lower in the neurodegenerative diseases. For one or two, we didn't see it higher in the ones in some of the cancers, but those are the exception to the rule. I believe 21 of the 25 conditions here that we've studied show a lower acute inpatient hospitalization rate for beneficiaries with this condition compared in Maryland compared to other states. So the difference is somewhat small, and we'll look at those differences. When you look at all conditions in aggregate, it's actually 18.2% of beneficiaries are going into the acute inpatient compared to other states where it's 19.1%, so about a 1 percentage point difference, but it is lower. Somewhat unsurprisingly, this trend persists in the post-acute care setting. Given that it's post-acute care, if they don't go into the inpatient to begin with, there's a high likelihood they're not going into the post-acute care either, though you can be admitted to these settings from community. And so there's a larger difference, and Maryland shows at least a percentage point difference, a greater difference in having less PAC utilization, both institutional and home health in aggregate compared to other states. And this is true for 23 of the 25 conditions. And so you'll see that blue line higher, or it almost looks equal for one or two. I believe it's the cancers again. So cancer urologic, for example. So in conclusion, we saw in general Maryland's higher cost on total mean annual spending, though when we break it down by setting, they have lower acute inpatient utilization, though the reimbursement rates in that setting are reimbursed higher and could be driving that total cost or one of the main contributors. It's still a reassuring finding to see that the chronic condition beneficiaries are kept out of the inpatient setting relative to the other states in Maryland compared to Maryland. And so we want to ensure, as I kind of touched on in the introduction, that this trend persists post the COVID pandemic. And what we really are looking at is the utilization of acute inpatient and the utilization of post-acute care in Maryland compared to other states for a benchmark period and a post-COVID period. So we only had available to us the first 2 quarters of 2022 to mimic both the data runout, and the amount of time data has to mature, and align the study periods. We're comparing this to 2019 Q1 and Q2. And so the first thing to note, if you look at any of these rows, let's just look at the first, is that they've dropped substantially in 2022, all the utilization, whether it's Maryland or other states. This could be because of the effect of patient behavior after COVID. That's one contributing factor, but it also could be a factor of the query itself and the time that claims need to mature and come in to our study. And so while it's interesting to note, what we're really most interested in is assessing this in a diff and diff so that we can hold constant any differences in the benchmark and post-COVID period that could be data-driven or behavior differences, and really just isolate the difference between Maryland and other states. And so by difference in difference, I want to see how different is Maryland compared to other states, and is that percentage different, persistent in 2022? So to step through this for the acute inpatient, Maryland has a 0.4% fewer percentage point difference compared to other states for patients going into the acute inpatient. This difference has decreased in 2022 to a 0.2% difference, a percentage point difference, excuse me. The similar trend in post-acute care. So really, Maryland is still showing a lower utilization rates of these settings, but the gap is closing. Now, another thing to note here too is the numbers we had been showing up to this point were for 2019, the full annual year. So, I just quoted something along the lines of 18.2% of Maryland chronic condition bennies have an acute inpatient admission. And now I'm showing you 11.1 here. That's a result of us only looking at the first 2 quarters. And so here it is as a bar chart for acute hospitalization. And again, it's much the same story, but the gap has closed somewhat. And same here. Now we're looking at the differences in PAC utilization. So to summarize, first data research limitations and improvements, and then our final findings. Increased sample size and studying additional years is always interesting. I think the check of inpatient and post-acute care utilization in 2022 really shines a light on. It would be interesting to look at the total of 2022 once that data is in and matured. And as time transpires further and further from the most intense, hopefully the most intense parts of the COVID pandemic. Payment standardization, a process to remove some of the differences in cost reimbursement unrelated to the care condition, could be an interesting way to look at these figures as well. Rather than just looking at allowed amounts, looking at standardized allowed amounts that are going to remove things that shouldn't look like resource use, right? An example of that would be some kind of percentage bump or deduction on your inpatient claims as a result of the value-based purchasing program. Accounting for the patient complexity could be interesting. We saw in aggregate, there wasn't a huge difference, but when you break it out by condition, there could be substantial differences. And so, holding constant the patient case mix and comparing cost after that is taken into account could help identify appropriate resource use. And then the last kind of critique of this research to keep in mind is that we kept doing all costs. These were total costs over the year, total costs in these particular settings. And actually there's no relatedness of that service being particular to treatment or maybe an adverse outcome or related to that condition itself. It's more big numbers. Hopefully, the trends are floating to the top. But if you were able to refine the cost to only look at services, for example, that are related to treating diabetes or a consequence of diabetes, this clinically refined cost figure would speak probably more directly to the care utilization for that particular condition. Okay, so in summary, overall, the mean annual allowed amount per beneficiary tends to be higher in Maryland, with the exceptions being the neurodegenerative diseases. Maryland does have lower rates, though, of acute inpatient hospitalization and PAC utilization across the majority of the chronic conditions that we looked at, the vast majority of them. This could suggest Maryland is doing a better job in keeping chronic condition patients more stable through office visits, outpatient, and other care settings that they don't need the acute care hospitalization in other states. Though the magnitude of this difference has decreased, while Maryland is still having lower rates on this metric. In the first 2 quarters of 2022, the difference was not as large. But we do know that the mean allowed amount per beneficiary for acute inpatient hospitalizations are substantially higher. There's a policy reason behind that and a reimbursement reason behind that, and could largely be contributing to the finding about the total annual spending per beneficiary. And one that's not on here that I'll just throw in is Maryland seems to have a slightly more right skewedness to their cost, their total annual spending per beneficiary across nearly all the conditions compared to other states. And so when you look at the medians, Maryland is still higher, but the difference is smaller. And so there's particularly complex patients, or there seems to be a higher rate of outliers at the right tail of the Maryland distribution. Thank you. So thanks for coming today and listening. We can turn it over to questions now with the remaining 10 to 15 minutes we have.
Thanks, Sam, for that presentation. For everyone here, this is being recorded and it will be available on the CRISP Learning System website. Jessica did throw the link in the chat. So now we can start questions. Our first question is from Heather, and she said, what did you include in the post-acute?
For post-acute care, sometimes we looked at it by what we define as the traditional for post-acute care settings, and sometimes we defined it as the institutional. And so there was no particular delineation in the types of services or, the RUGs or the reimbursement rates of any particular state. So at times, if we said institutional post-acute care, we were including all skilled nursing facility, all long-term care hospital, and all inpatient rehabilitation facilities. If we just said post-acute care in general, and they would also include home health.
Thanks, Sam. So it looks like our next question is from Joe, and he says, are an increase in urgent care settings contributing to lower inpatient utilization?
That's a fair question. For each condition, I would have to look, using diabetes as an example, it's possible. I don't know the answer to that. But in many cases, we saw the utilization of outpatient to be lower as well, which is kind of the stratification I'd expect to see the emergency department admissions. It's possible, but we do not have those results, unfortunately.
Thanks, Sam. So that looks like it was our last question. We can hang on another minute if anyone has any other questions. But if not, thank you all for coming. So there is one more question. Heather is asking, could you please summarize your findings by condition?
Sure thing. This might take a moment to go through all 25. I'll pick two metrics. We'll start with the difference in mean annual spending per beneficiary in Maryland compared to other states as a ratio. So if I calculated the average spending per beneficiary per year on a condition in Maryland, and then I did that at other states, and then I divided Maryland by other states, we'd have a ratio. You could roughly interpret it as a ratio of 1 being equal, a ratio of 1.1 meaning Maryland's on average spending about 10% more, and a ratio of 0.9 indicating that Maryland is spending about 10% less in comparison to the other states. There's 25 to go through, but this is a recording, so those have to drop, that's okay, but I'll just list them off. Starting in descending order, at a rate of 1.32 is cancer endometrium. The next in a range from 1.11 to 1.17 are 9 conditions, which I'll rattle off in descending order. Cancer, urologic, heart failure and non-ischemic heart disease, chronic kidney disease, cancer, colorectal, COPD, asthma, prostate cancer, depression, bipolar, and other depressive mood disorders, and breast cancer. The next set are all nearly equal. They have a ratio of 1.1 to 1.08. I'll be listing them in descending order. And there's 10 of these. Oops, I left the aggregate line in there, but that's okay. So lung cancer, then all the conditions in aggregate, then ischemic heart disease, atrial fibrillation and flutter, hypothyroidism, hyperlipidemia, rheumatoid arthritis / osteoarthritis, anemia, hypertension, and diabetes. 3 additional, ranging from 1.06 to 1.02, is glaucoma, benign prostate hyperplasia, and osteoporosis, excuse me, with or without pathological fracture. And then the last 3 are the ones we kind of highlighted, which are the neurodegenerative diseases, where the ratio is actually under 1, going from 0.98 for Parkinson's disease, 0.98 for non-Alzheimer's dementia, and 0.84 for Alzheimer's disease. There's also results to be summarized in terms of the inpatient utilization, which I find particularly interesting. I'll just note some of the highlights. There's 4 conditions where Maryland has a higher proportion of their beneficiaries in a chronic condition with having inpatient utilization as compared to the other states. And again, I'm going to calculate the percentage of beneficiaries for that condition that had acute inpatient care. For Maryland, I'm going to do the same thing for other states. And then I'm going to take a ratio of Maryland over other states, where a ratio greater than 1 would indicate higher utilization in Maryland. So there's only 4 where that ratio is greater than 1. It's on the magnitude of about 1.03 or 1.02. So there's not a large difference. And this is endometrial cancer, urologic cancer, heart failure, and non-ischemic heart disease, and depression, bipolar, or other depressive mood disorders. And so we saw at least cancer, endometrial, and urologic cancer also at the top of the mean annual spending differences. The remainder of the 25 that we studied have rates less than. Maryland has rates less than that observed in other states. Highlighting maybe the bottom 7, which are on the order starting at 0.94, so maybe a 6% less difference. Ranging all the way down and decreasing to 0.88 in descending order. You have rheumatoid arthritis, osteoarthritis at 0.94, then diabetes, hypertension, hyperlipidemia, glaucoma, Alzheimer's disease, and osteoporosis with and without fracture. And then those I didn't mention, or like in the aggregate, the ratio of IP utilization in Maryland compared to others is 0.95, so about a 5% less in Maryland.
Thanks, Sam, for answering that question. I'd also like to point out, William put a note in the chat that we are looking at specifically analyzing the impact of urgent care on acute spending as a report in the next set of the Learning Collaborative reports. So everyone definitely keep an eye on the CRISP website in the future. And our next question is from Amy, and she's asking, was Maryland's participation in the HSCRC taken into account regarding the impact on the overall spend being higher in Maryland than other states?
I'm not familiar with the HSCRC, but I would hazard a guess that no, was not. in that we looked at Medicare Part A and B claims allowed amounts with no standardization or adjustment to the cost figure other than that observed in the claims data.
Thanks, Sam. And for anyone on here who doesn't realize, HSCRC is the Maryland Health Service Cost Review Commission. Our next question is from Brian, and he's asking, for those less mathematically inclined, if you had to invest your money in tackling one or two of these conditions, where would you focus your efforts?
Interesting question. I think there's a few metrics that would be of interest. I'm kind of filtering my results really quickly. There's something to be said of just looking at where Maryland is most spendy in comparison to other states. But there's also a volume question of, while they may be much more spending for this particular condition, there's only so many beneficiaries here. And so your per dollar savings, while it might be high, can only be applied to a small cohort of beneficiaries. So the cancers, including endometrial and urologic, they have the highest mean annual spending compared to other states, but they do have a small case count of only 300 to 400 per 100,000 beneficiaries. So while I think it would be useful to focus there, you might also want dual efforts on conditions that have a higher prevalence. And so looking quickly through these, diabetes and rheumatoid arthritis, while the spending differences between Maryland and other states aren't as egregious, or there isn't that large of a spending difference, it's still such a substantially large patient population that even saving $1 here per beneficiary is going to scale to overall savings quite a bit. And so, my recommendations would be where Maryland is the highest in comparison, but also the kind of highest volume diseases where Maryland is observed to be higher, even if it's not that much higher. And so the former bucket was endometrial cancer and urologic cancer, and the latter bucket was diabetes and rheumatoid arthritis. I'd also highlight heart failure and non-ischemic heart disease as both a nice middle ground of being, both high in spending, but also high in patient population.
This is Joyce from Acumen, and I think this also relates to some of those ideas that Sam had mentioned about potential future refinements to this research, where you could build on this to look more specifically at different types of cost drivers, and that could be a way of honing in on areas where there's the greatest opportunities for cost improvement. So that could be looking at things like, for instance, for diabetes, the rate of, say, hospitalizations for amputations, and getting to that kind of level of granularity to see where are the potential cost savings for each of the conditions, and how to go through those for each of those to really see, despite, in combination with the differences in cost and utilization, is just to see the degree of clinical relatedness and to see which of these are under the potential influence of providers.
Thanks, Sam and Joyce. Our next question is from Heather, and she said, did Maryland have 2.7% savings on chronic conditions? If she wrote that down correctly at the beginning of the session, and if so, was that due to a decrease in acute admission volumes?
Yes, this came from our environmental, yes to the 2.7% savings, unknown to the cost, whether it was due to a decrease in acute admission volumes. Now, this finding that we stated is actually on slide 3 in our background, was done by an environmental scan that we first conducted prior to jumping into research. We looked at established studies and research already in the public sector. And this was evaluating the first 4.5 years of the model. So not necessarily the empirical analyses we looked at today or conducted ourselves, but in a separate research paper to the start of the total cost of care model, they showed that 2.7% savings. And what it was, that particular metric, and we have this paper cited in our report and can share it after the call as needed, but it showed a 2.7% less decrease compared to the comparison group in the increase in spending. There's an expected increase in spending as time goes on, but prior to COVID. And that rate of increase was 2.7% less in Maryland compared to the comparison group. And the cause of that, we don't have.
Thanks, Sam. So it looks like that was our last question, and I'll just quickly highlight a conversation that happened in the chat. Rich said, therefore, the payments are not comparable because Maryland does not follow Medicare, IPPS, OPPS payments for acute hospital care. And William said that is correct. That is what Sam meant when he said we know why Maryland's IP costs are higher, because we haven't normalized that out, and that was beyond the scope of this study. So if that's the end of questions, thank you everyone for coming, and thank you Sam and Joyce for this wonderful presentation.
Thank you all, and thank you, Lexi, for the opportunity to present. Take care all.